So we've already heard quite a little bit today about genetics and atypical aHUS. And so it's great that we've got a human geneticist with us today, my wife Judith, who we've been working on the disease now for over 15 years. And I'd like to think that she's both the brains and the beauty behind everything that we've done. And so I won't say any more, but pass her on to you to talk about genetics and aHUS.
But that's not actually true. I'm not the brains behind the whole thing. So we've heard from Matthew and Sally this morning about complement dysregulation in aHUS, and you've heard about these proteins, the complement regulators, factor H, factor I, MCP, that's also known as CD46, which is a bit confusing. And also we heard about overactivity of some parts of the complement system like C3. So changes, faults in any of these proteins can cause aHUS. If you've got a fault in a protein, it's because the genetic code to make that protein is faulty. So I want to just take a few minutes just to talk about how genes are inherited and how they're passed on, just so that you can think about how it works in your family. So genes are on things called chromosomes. And this picture shows chromosomes which are numbered from the biggest, number 1, down to the smallest, number 21 and 22. The reason that I'm showing you the chromosome picture is because that shows you very clearly that for each chromosome that we need, we actually have 2 copies. So you can see we've got 2 number 1 chromosomes, 2 number 2s, and so on. For each of these chromosomes, we inherit one of the pair from our mum and one of the pair from our dad. When we have children, we pass on one of each pair to each child. And you can see here that the various proteins in the complement regulation are on different chromosomes. So factor H and MCP are on chromosome 1, factor I is over here on chromosome 4. So they're dotted around on different chromosomes. But the principle is the same, that we have 2 copies for each one, 2 copies of the gene for each one, which is shown again here. So here I've taken out the other genes and just left factor H there and shown that we've got 2 copies of factor H gene. So if we've got a fault in, as denoted by the yellow circle, if we have a fault in the gene that's going to make faulty factor H, somebody who has that fault will be making a mixture of normal factor H and the faulty factor H. The fault that they have, they might have inherited from their mum or their dad, or it might be the result of a new copying error, a new genetic mistake in them, so not present in mum or dad. But if we look at the families that we've studied, what we find is that overall about 80% of people who have a factor H mutation have inherited it from one parent or the other. So even though something presents as what has been called sporadic, i.e. the first time it's happened in a family, aHUS, there is still a significant chance that the gene fault will have been inherited from either mum or dad. And when this person who has the faulty copy of factor H has children, they will pass on either the faulty copy or the normal copy. And that's why it's a 1 in 2 chance of passing the faulty gene on. So it's very straightforward. It's a 1 in 2 chance of passing the faulty gene on. You may have heard doctors refer to this type of inheritance as autosomal dominant. So a bit like Sally and Matthew saying what words mean, that just so that you're not, to remove the mystique of these words. So dominant is where one faulty copy is enough to give you a problem. And the term autosome refers to all of the chromosomes apart from the sex chromosomes. So over here we have the X, this is a lady's chromosome pattern, so this is 2 X's. So all of the other chromosomes are known as autosomes, and that's why it's autosomal dominant inheritance. So when we draw a family tree, we use a sort of shorthand way of drawing family trees quite quickly. And in essence, all of the circles are ladies and all of the squares are men. And if somebody is affected by a disorder, then we fill in the square or circle. So here we have an affected person in this top generation, and 2 of their 3 children are also affected. And likewise for the affected individuals, you know, they have a mixture, or they have some normal children and some affected children. If we put a line through somebody, it means that they are deceased. So that's the shorthand when you're looking at pedigrees, how to interpret a pedigree. So this would be a typical family tree for an autosomal dominant disorder, where basically people who have the disorder can pass it on. Again, people who have it can pass it on. But the difference, or the thing that's unusual about aHUS, and it's something that has been mentioned several times this morning by Margaret. So Margaret was telling us that she has 2 boys, 2 sons who had aHUS, but she doesn't have aHUS herself, so that normal people who carry the gene fault don't necessarily get the disease. And so when you look at the pedigree, sometimes pedigrees look like this. So here you've got somebody who clearly must carry the gene fault because their parent had the problem, they've had children with the problem, and yet they themselves have not yet developed the disease. Sometimes we denote these people on pedigrees by putting a little black circle in the middle of the circle. So our data about what proportion of people do develop aHUS is based on few of the large families that have been studied, like Margaret's study. And when you look at those families, you find that 1/3 of the people who carry the gene fault develop aHUS by midlife, and another 1/3 will develop aHUS by the time they reach old age. I'm not quite sure how old age was defined in this study, but which means that 1/3 of the people who carry the gene fault never go on to develop the problem. And I think that's quite important to remember, that not everybody who has the gene fault gets the disease. So what I wanted to do next, a little bit like Margaret, was to ask Sean to come up and talk about his family tree. So that's the sort of the very shorthand version of his family, but he's going to talk about his family. And just so that Sean was really the person who prompted the start of this research altogether, really, because it was seeing Sean with his nephew Mark repeatedly dialysing in Newcastle that led Tim to want to study this condition. And Sean, over to you.
Push the red button.
Push the red button.
Okie dokie. Good afternoon, ladies and gentlemen. It's really a privilege to be here today, to talk to you all, and to see so many knowledgeable people, the doctors and the scientists, the people who have actually brought us all here today, and who have brought all of the research to the fore in as much as they can with the technology and the knowledge that they have up to now. What I'd like to do today really is to try and give you a family perspective of what it's like to be involved with this kind of disease. It's something really that quite a lot of doctors quite often just simply don't have the time to kind of really get into, because they're so busy. They see you in clinic and they're by your bedside. They don't have a lot of time to get into that kind of issue. So today I hope I can get across to you just how really that individual family perspective drawn out over a long period of time has affected us as a family. I'd just like to go through this chart with you just very quickly, just to kind of give you an idea about who's who and what's what. Top right here is my dad's mum, who was obviously affected and died from renal failure. Coming down, this line along here is the siblings from Grandad and Grandma at the top here. These two people at the end here, the left one and the right one here, both coloured in black. That was my dad and his twin brother. Both of them had aHUS, end-stage renal failure, several transplants, didn't work, unfortunately. This is my mum here. These people were unaffected until you get along to 11.7 here. These were two brothers that died much, much earlier on in their lives. My dad and his brother survived up until the mid-50s. And then carrying down now into our own family. This is a sister, this is a brother, and this is myself here. This is a negative sibling and another negative sibling. Going back up to my dad's family line, I had an uncle who was positive, lived well up into his 80s, very, very fit man, walked everywhere. He had a son who unfortunately succumbed to the disease when he was about 7 or 8 years old, I believe. So you can see that the family's littered with areas of time where this awful, creeping ghost of a thing just kept striking the family time after time after time. And back in the 60s and 70s, offered blood tests. They could never ever say, you're positive, you're negative. What do we do about children? So really, our awareness has greatly, greatly increased over the years, and I think it's probably just, it's kind of coming to a peak now where this new thing is being introduced into the system, and that makes us change our thinking. Yes, children, the negative and the positive side of the testing meant just a few years ago that we were all given the opportunity to give blood, and some of us got a positive back in terms of, yes, you are positive, but you're unaffected. And some of us got a negative back. You are not affected at all. So that left some people feeling, as you can imagine, quite kind of struck by this, by the sheer knowledge that you have something in your system that could attack you at any time. We don't know what the triggers are. And yet you have the other people who can kind of walk away to a point because they're not affected, but things still affect them because they might feel guilty because I'm not affected by this, how can I help the rest of my family? It's difficult. The effects on the family are numerous, and I'm sure that there's a lot of people in here who would say, yes, I definitely know what they all are, and I can identify with maybe with some of the things that Sean's saying today. The rigours of dialysis are terrible for an adult, really, under certain circumstances, depending who you are, what you have wrong with you, what your view on life is. Worse again for children. Terrible, terrible, terrible for children, especially if you're the parent of that child. That gives you a really, really different perspective on how do we move forward with this? What do we do with this? It's such a destructive thing. It might not necessarily, I don't think, maybe kill as many people as it does today because of the knowledge that doctors and specialists have in this area. But dialysis itself, dialysis is tough. I don't care what anybody says. It's a tough regime to stick to and to actually run with. I find that as an adult. So what a child must think of that, I don't know. But they do get children through it, so that just goes to show the knowledge and the professionalism that the medical authorities have. Anxiety around what's there in the future. Pain, suffering, both physical and emotional. It has to be there. You can't avoid it. You can't run away from it. You've got to face it. You've got to try and do what you can to try and move you and your family forward with a particular issue, a problem that you may have sitting around in your molecular structure somewhere. It's just there. And like a lot of other families, I'm not saying that we're terribly different. Other families may have other types of genetic problems. But now that we've put so much into this and we've lost so much, we really, really feel that we need to really push this forward and try and do as much as we possibly can to help not just our family. It's not just about us. It's about thousands and thousands and thousands of people, not just today, but people in the future as well. The bereavement and the losses, particularly bad. One person in our family described it as devastating. And they're very, very predictable as well sometimes. Maybe not so much these days because of the technology and the advancements. But with the new things coming up and the new knowledge that we have, we know who's positive, we know who's negative. It puts us in a really, really, really much, much, much better position than we've ever been in since maybe the 1950s. It's that creeping, horrible thing that's hanging around the corner. And because it doesn't just strike elderly people or people who are middle-aged, it strikes children and young adolescents. So for us to get this far, it's just a fantastic achievement, and I can't thank all of the people involved in it enough. Thank you.
So thank you very much, Sean. So as you can see, this disorder has not been kind to Sean's family, in that he's the only surviving person with the disorder in his family at the present time. And the age at which it's presented in Sean's family has been very variable, several people being affected in early childhood, his father in his 40s. So it picks up some of the points that were made by Margaret with reference to her family earlier. So I wanted to come on to think about genetic testing and the role of genetic testing and whether it's a good thing or a bad thing. As you heard from Sean, he and his family decided they would ask for genetic testing and have it. And I think that you found that this was an empowering thing, that this made you feel more in control of the disorder. Is that
Yeah. It is massively, massively empowering, because before we had absolutely no knowledge whatsoever about who was positive and who was negative and what kind of impacts that might have on their lives, especially with regards to family planning.
Right, okay. So the medical perspective about genetic testing is a little bit different, but perhaps the medics should listen to families much more often. So the medical perspective on genetic testing, we think about it really in testing an affected individual or testing somebody who's at risk, so a parent or a brother or sister or somebody who's part of a family. Testing the affected individual is very straightforward. You're trying to find out what's the underlying basis of their disorder, because it might affect the way you treat them. It also does give information to their extended family, so that's very straightforward. But the at-risk individual is less straightforward. So from a medical perspective, there are some disorders where we think it's absolutely clear-cut that you offer testing and try and encourage people to have testing. And those may be disorders where there are well-known precipitants, and whether it's a a medication, sometimes quite common medications, where you can say, if somebody carries the gene fault, just avoid this, this and this, and then you're all right. But we know that's not the case in aHUS. There's nothing we can really tell you to avoid. The other time when genetic testing is, another time when genetic testing is recommended is if you can screen for complications. So there are some disorders where the onset is insidious. You can think of some of the cancer-type genetic conditions where somebody might have a tumour, but there'll be quite a long time before they present feeling unwell, and you could have intervened, you could have treated if you'd known it was there earlier. So if we think that you can screen for complications, then again we might recommend carrier testing, but that's not really the case for aHUS either. And for some disorders, one can actually start a treatment before somebody feels unwell that will postpone or prevent the problem, and that would be a good reason for finding out early. But that doesn't really apply in aHUS either. So from a medical point of view, there isn't sort of an imperative to test. Apart from those people who are thinking about giving a kidney, and I think if somebody's thinking about donating their own kidney and you know there's a mutation in the family, a genetic change in the family, you'd want to test them because you know that removing their kidney puts them at, or if you do remove their kidney, there's a high chance that they will then develop aHUS. That's almost like one of the biggest triggers for developing aHUS if you take somebody's kidney, one of their two kidneys out. So that would be a very strong medical reason for saying, let's do the genetic test before we remove a kidney. But other than that, there aren't strong medical reasons for doing the test. So then it's really very much up to the individual. So sometimes people want to have information because they will change their decisions. They will say, perhaps they will say, I've already got some children. If I knew I was a carrier now, I wouldn't have more children, or something like that. Sometimes people offer to be tested because they know that it helps us to gain more information. So if we get more and more information on people who are known to be carriers but who aren't affected, then maybe that's the basis of us working out better figures for what proportion of people actually do go on to develop disease. Maybe helpful for us to work out what are the triggers to actually work out who might develop disease. So somebody might offer to be tested because it's helpful to genetic research. But whereas from a medical perspective, we sometimes think that having information that doesn't change anything isn't very useful, I think that for some families, and certainly for Sean and his family, they've found that just knowing helps them to know who's at risk, to notice signs sooner, take people to the doctor sooner, just be looking after their family better. And so having that information is a huge help to them, though I recognise that not all families will take that same line. And I think that it does pick up on a number of the talks earlier this morning that the families looking after each other within a family is absolutely key. So Margaret was saying that she spotted diagnoses in the younger members of the family really and informed doctors rather than taking a child along and saying this child's unwell, what is it? You were at one stage ahead of all the medical professions. And I think that having the information for those who want it is another way of putting you one stage ahead and giving you ownership and of the disease in your family and putting you in charge and looking after your family. So I was going to stop there and ask what your experiences or thoughts are of testing, when you might want to be tested, or pros and cons of testing, and also, of course, for us to answer any questions you have about testing. Thank you.
Thank you, Judith and Sean. So, questions for either or both of them? Can we use the microphone because
It's just going.
If you want to be tested, is it something that you should just think of in your own right as a one-off person, or from a medical perspective, should you involve other people in the family to give you more information? Does it matter really how it's done?
Well, I think the only decision is to make your own decision, isn't it? But obviously, if you then find that you are a carrier, that then puts the onus on you really to think about, should I tell my first-degree relatives. So it does reach out into the family, doesn't it?
I mean, I personally would like to be sort of tested, but when I raised the question when I was actually at the hospital, they said, well, really not going to have any more children, there's no need for you to know. So, which is contrary to, if I'd been offered the test, I probably would have taken it. But.
Yes. I think the other reason you need to know is we've already said that this is a disorder that can still affect people as adults.
Yeah. Which I didn't know until today, so I was completely gobsmacked by that. That's something, that changed my whole perspective on it, really. It's not just your child that you're worrying about. Obviously, your child's more important than your own life, but it's something you have to consider now as part of the whole picture, and I didn't have any idea that carriers could actually develop it. Yeah. From what we were told, it was something that typically occurred in children prior to sort of 12, sort of 13 years of age, and if they got beyond that stage, then really it was very unlikely they'd ever develop it, and similarly with adults. So what I've learned today is I'm just amazed, really. It's a lot more information I've learned probably in the last year.
Yeah, so sadly, yes, it's not the case that if you get to 12, you're in the clear. So
no, clearly not. No, so I'm really glad I came.
Yeah,
really glad.
Okay. Yeah.
More questions? Was one at the back. Have you got a microphone?
A couple of things, really. I mean, first of all, one of the things about testing is that if you're tested and you're tested positive, is that your insurances and anything like that is going to go through the roof. I know because I've got my sister's got atypical aHUS, but I've got another genetic condition, and because they now know that I've got this other genetic condition, our insurances are absolutely loaded. Struggle to get insurances with some companies for mortgages, life insurance, travel insurance, so it impacts on that side of it. The other point is, you're saying that there isn't any known triggers. We've been told by a consultant that the contraceptive pill is a known trigger, and my sister has been told that her daughter should never be allowed to go on the contraceptive pill. Is that correct, or is that misinformation, or...?
Some of the clinicians may want to join in on that, but so pregnancy, there are a number of reports of people developing aHUS after pregnancy or after starting the oral contraceptive. I suppose then it's a question of what level of risk, what is the chance of developing aHUS? So certainly for pregnancy, where it's a recognised trigger factor, about 1 in every 8 pregnancies, there will be aHUS at the end of it. So then it comes back to personal decisions, doesn't it, about how you weigh risk against how you weigh. For the oral contraceptive, Tim, do you have a figure for that?
It's sort of the thing that's been reported long-term anecdotally, but there have never been any good, what I would call medical, trials to say, is it definitively yes or no? So it's the sort of thing that sometimes gets passed down in medical literature, and then when you go back and say, what's the evidence for this? It may be, one person reporting a case 15 years ago, and so I wouldn't. I'd say there's things that are suggestive there, but not definitive.
I suppose this is another place where the registry that Mark was talking about may enable us to actually definitively answer some of the things that are anecdotal. I can see Margaret's asking a question, but just to come back to the insurance issue. So one really does have to, as you say, read the forms very carefully from the different insurance companies to see what questions they're asking. Most of the insurance companies now ask, is there a family history? And if they say, is there a family history, they load you anyway.
Yes. Yeah.
So actually having the gene test doesn't actually make it... So there is already there is already a waiting on insurance, but having the gene test doesn't make that much difference to that waiting if you find the right company. Yeah. But I see that is a problem. Yes. So there was somebody.
Margaret,
there's somebody at the back
Sorry.
who's just going first.
If you've had a transplant and the person who donated the kidney has other children but by a different biological mother, and the person that received the kidney is actually fine, well and healthy now, is there a chance that the genetic side had been missed on the mother's side rather than just testing the father, because the mother was never tested? And is there a chance that because that never happened, her children or her siblings were the same.
Can I just clarify that family structure? So you've got somebody who's received a kidney,
Yes.
who's affected. They received it from whom?
The father.
From their father. And
That father now has 2 other children by a different biological mother.
right.
It's not the same mother.
Yes. Okay.
Now, what I'm concerned about, if they weren't tested,
So the person who donated the kidney,
if he was negative and it can skip a generation, is there a chance his other 2 children could have a dormant gene?
so if the person who donated the kidney was genetic tested not to carry the mutation, he can't have passed it on to his subsequent children.
But we don't know if he was tested.
Right.
But because he donated, would it have been automatic?
No, because, well, it depends when he did it.
2 years ago.
Oh, 2 years ago. So one would hope that he would have been tested 2 years ago. One would hope that he had been tested.
So there's less chance of the other children having the aHUS
Providing he
gene.
was tested, there's, if he was tested and he didn't carry a mutation, there's less chance of his children being affected, yes.
Can he ask to be tested now if he wasn't tested then? As a
He could
protection
be.
or a precursor?
He could be. The other thing that we should, of course, remember is that the person he donated, the place you have to start off out with is the person that received the kidney,
Right.
whether the gene fault is known in the person who received the kidney. Because as we've talked about all of these causes of aHUS, we have to come back to remember that we only know the cause in about 70% of patients. So you'd have to start off saying, did we know the cause in the person who received the kidney?
No.
No. So if we don't, then testing their parent isn't going to help you
But
really,
the
because you have to know what you're looking for.
Yes. Right.
So if the person who received the kidney is one of those 30% where we just don't know at the moment why they got it, then you can't really test the parent. So there were 2 more people. There was 3 more people.
One of my sons donated a kidney 18 months ago to an unknown patient in order for me to receive a kidney. And I have aHUS, and unfortunately the aHUS rose up and attacked my new kidney that was donated. Now, if my son is a carrier, which we don't know because none of us have been tested, will he now have passed aHUS on to the recipient of his kidney?
Not necessarily. So you say you haven't been tested, so we
No,
don't know
because
which gene.
No, I was actually going to say to you, how long have these tests been in the picture? Because I got the impression there wasn't a test, and we were told not to worry about it because the chances of our children, our 4 sons, having the disease were remote because it was so rare. So how long have these tests been available?
A few years. A few years, yes. So thinking back to your question about your son, so it's very good that he's given a kidney and not run into any problems himself. That's great. If the cause of the disorder of the aHUS in the family is a factor H problem, then giving the kidney wouldn't cause aHUS in the recipient because the recipient makes factor H in their own liver. Wow. Whereas if the cause of the aHUS in your family was, say, an MCP, a CD46 change, and you gave your kidney, that could cause a problem because CD46 we make in our kidneys. So,
but Tim wasn't, one of the tests he had, he wasn't tested for aHUS at all. So
right.
I got the impression that nobody would have been tested for aHUS.
But it might be worth going back and just saying, I'd quite like to know if I carry a gene fault.
Yes, yes.
Just
Well, I'm very interested now in this genetic
Right.
testing.
Okay.
Yes.
So
Okay.
Margaret has been waiting a long time.
I've probably said too much already. Picking up on the question about the contraceptive pill, back when our children were poorly in the 70s, there were 2 other sisters that came in, not related to us that I'm aware of, but they had both been given contraceptive pill, and it, you know, was obviously that started the condition off and was a trigger in theirs.
I suppose in a way that even though it's possibly a small risk of the oral contraceptive triggering the disorder, when there are so many other options available, maybe one should just take one of the other options for contraception.
But I think then, I mean, the contraceptive pill in the 70s is somewhat different than it is now. So,
Yes.
you know, and can I just say about families being tested, as I said earlier, a lot of our family were tested in 2005. We actually went and to the local hospital and had a number of clinicians, if you like, come and take our blood and test us. But we did it with my children, if you like, that generation, not with the little ones. And I think the comments that we've made, if you test the children, you worry about them all the time. And whether that's a good thing, I don't know. Because you're obviously aware, if you've got the gene, that you could pass it on. So if your child becomes ill, you would immediately question it, whether you've tested for that gene or not.
But I suppose if the disorder's in the family, you have a very high level of awareness. Whether you know that they've got it or not, you still have a high level of awareness and thinking, I think I should take them to the doctor sooner rather than later, don't you? So, yeah. I think David was trying to make one point before we...
Obviously, being Scottish, I was kind of interested in the aspect of insurance. And you said it's already weighted if you've got a family history. If you get gene tested, can you renegotiate your premium? And are found to be negative, obviously.
So some of our families from, not necessarily aHUS families, but other genetic disorders, have gone back to insurance companies and asked for a reduction in their weighting. And some have achieved it. But, so I think it is a possibility. Yeah.
Our son has been tested and has been found to have the CD46. And we have a daughter, and we very recently, literally 3 weeks ago, got the results back from her, which on the face of it looked to be, you know, she's fine. Mm-hmm. We had to push for that to a degree because we were told that the chances, again, would be absolutely negligible. But, you know, through us sort of nagging, to be totally honest, we got that done. One thing I'm amazed today, which one of the other participants mentioned, is that I had no idea that we potentially were at risk. What rights do we have as patients to demand to have this test done?
Well, I think as patients you can ask for the test, and I don't think there's any reason why you would be turned down. I think, so as parents, I think it's, if you want to know, I think it's, you should be able to know.
Right.
If you, yes. So I think that's important. I think where doctors around the country have a much more varied response is when they're asked to test young children. Because often the traditional stance has been that we shouldn't test children for things until they're old enough to understand what they're being tested for. So that was the traditional stance, that the child had a right to say when they were tested, when they understood. But the more I work with families, the more I think this is very much a paternalistic, a doctor-imposed position, and that maybe the families know best, really, and if the families feel that they will handle the situation better, if they have all the information and they'll know who to really look out for, I think the families are probably right there, and I don't think that we should turn down requests to test children either. Obviously, as Margaret says, some families will say, well, we don't want that information right now, and that's perfectly reasonable, but I think if a family says that they want that information, it will help them look after their family, then who is the doctor to say, you don't know what's best for your family?
The way it was explained to us was because the test is more from a research point of view rather than a medical point of view, that there was no sort of weighting on it, and it was almost at the discretion of the testing centre, as and almost our doctor, as to whether they were prepared to put that forward.
Well, I think where we should be moving to is saying that that it's at the discretion of the family rather than the discretion of the doctor. I think that's where we should be moving to. And I think there are pros and cons. I think it's a finely balanced thing, whether it's right or whether it's the right thing for a particular family. But I think maybe the family, if they have the chance to explore the pros and cons, are ultimately the people who should make that decision rather than the doctors making that decision or refusing, declining a test. Though, as I say, that as I start off at the beginning, the traditional point was that doctors could see there was a point in genetic testing if it changed how you treated something, if you could do something. But actually, even where from a doctor's perspective you're not doing a lot, I think for the families that can sometimes still be very useful information to have.
Thank you.
Any more questions? No? Okay, well, thanks very much, Sean and Judith.